Hello and good evening. We're going to be covering the clavicles, SC, and AC joints today. Of the three, we'll probably be doing the clavicles more than anything else. The sternoclavicular joints aren't very commonly ordered. Just there's not enough separation normally in there. Occasionally you will do the AC joints because it is an area near the outside of the shoulder laterally that's a little bit more prone to injury. Clavicle or collarbone seen here, you're going to be bilaterally on both sides. It's going to articulate at the SC joint right where the sternum and the clavicle meet, and then out here where the acromion of the shoulder comes out, it will articulate at the AC joint over here. The rest of this is just bony anatomy kind of pointed out through here. Clavicle has a very unique shape to it going across. When it's placed in the skeleton, the anterior portion will be towards the midline, towards the SC joints, and then it'll kind of have this gentle kind of curve towards it near the shaft of the clavicle before it ends towards the AC joint near the shoulder blade. Something to pay attention to is the conoid or conoid tubercle, which is out through here. Normally you're not going to be able to see that on the AP view, but when you do your AP axial view, you should be able to see that clearly towards the lateral portion of the clavicle. Positioning, rather simple. There are just two positions. There's going to be an AP and an AP axial view. Generally, you can do these standing or sitting, ideally. If you have to do them lying down, you can do them in a supine position, but you'll have to add a little bit more angle to it. Typically, what you're going to use is just a 10 by 12 crosswise film. It's going to be longer side to side than it is up and down. You're going to use this in the bucket. You can adjust your KVP depending on what type of equipment you might have. 40 inch is going to be your SID. You do not need a 72 inch SID for this, since we are only doing one of them typically. Central ray is just going to be perpendicular to the film. You're just going to really center just midline to this. So you're going to find the medial line, which will be the SC joint. You need to make sure the entire head is on there. As it goes out towards the lateral border, you need to make sure you get that articulation where the AC joint is. As long as you have that all the way on there, you are fine side to side. Top to bottom, it's only about 2 to 3 inches from its medial portion to its lateral portion, with a little bit of discrepancy for some patients. So you have to actually put your finger on the good clavicle and then just kind of look where the AC joint is, and then you can kind of get the general shape of it, and you know how much you have to leave it open top to bottom. AP axial view, depending on the book, which book you happen to have, we're going to go with the Merrill's. So Merrill's says 0 to 15 degrees of the cephalic angle should be used. This right here is the old Bontrager. Look at it. The real only difference is if you use the 15-degree angle on both patients is that this patient here will be in a more lordotic position that you'll see in the book. So similar to the lordotic chest we did, we just have them move forward about a foot, lean back, and then we put a 15-degree cephalic angle going up. Just make sure your marker is towards the outside. Should use about the same amount of field size. It's not going to change that much. It will distort it a little bit, but you'll be able to see the underside of the clavicle a little bit more. This view right here is your AP. You can tell that it's AP because the clavicle is going straight across here. The 4 points that we're going to look at, so you're basically going to look at the level of the clavicle. If it doesn't look distorted at all, typically that means it's AP. If it's an AP axial, then it's usually going to have a bend underneath here where you can see. The second point you're going to look for is this area right in here. This one, you're not going to see the conoid tubercle here at all, but on this one here, you can see this little point coming out, and that's your little tubercle kind of sitting towards the outside in there. Third area you're going to look, so all you really need to do is look at the superior angle. As you look at the superior angle, we talked about the shoulder, it's going to be about level with the mid shaft of the clavicle, sometimes a little bit higher, but when you put an angle on it and do the AP axial like you see here, there is always going to be some space between the top of the superior angle and the bottom of the clavicle here. Last area to look, just look at the shoulder or the humeral head right through here. Humeral head will normally lay within this glenoid fossa pretty well, and you'll see some spacing between the superior part of it and the acromion. When you angle up like this, what you're doing is you're basically driving that head of the humerus up into this area, so it's going to be a little bit closer to the AC joint, a little bit more overlap with the bone in here. So now we don't see this joint space going across on top here. Weight-bearing AC joints, you're typically going to do these with weights and without weights. This is just going to show some shoulder separation, which involves the supporting ligaments in the AC joint. So any of these ligaments, if they become ripped, especially across here, if you lose this AC kind of joint ligament going across here, what happens is the pressure of the clavicle will force it to go up, and you'll actually see a little bit of spacing in between the acromion and the clavicle here. You are going to do this with and without weights. You want to put a little bit of pressure on it. So the first one without weights is what you'll do first, a little bit simple. Second one, they're really just going to hold still, but you're going to add the weights on their wrists, like we talked about with the cervical spine a few weeks ago. It needs to be placed on the wrist, and you want them to have, you just kind of let the weight pull down as much as possible, because that will show any type of AC separation pretty clearly. This just goes into it a little bit. You can do these single, or you can do them together. Typically the radiologist prefers them together, so if you are using a 14 by 17 crosswise, which you should, you do need to do that at 72 inches. This is how we're going to practice it in class as well. Some places, if you only have 10 by 12 films, you can do them separate, one here, and then one with weights, and then one with weights over here too. So that ends up being 4 images instead of 2 images, which is not ideal. It should be done on expiration. We want the shoulders to drop as much as possible. We are getting the entire length of the clavicles on here, all the way to the outside, past that area a little bit, because we want to see the acromion as well. So we're not going to collimate side to side. Top to bottom, we'll probably leave it open by 3 to 5 inches, depending on how their clavicles are shaped, similar to the clavicles that we just covered. Some AC separations, so the radiologists are going to draw lines across the bottom of the clavicle, kind of match it up with different parts of the acromion on here. If there is a separation, which is pretty obvious that you can see here, that is very helpful to have the other side, so you know what is normal for this patient. This could look like a separation on some patients, but maybe this is normal for this patient. But when you look over here at the right side, you see the amount of separation between the acromion and the clavicle here. So this looks like a full tear between the AC joint. This is what a normal AC joint typically looks like. It's going to be lined up along the bottom of the acromion, a little bit of spacing across here, but that separated AC joint, the ligament's been torn, and it's kind of falling away from the rest of the bone. An alternate supine position that you can use for the AC joints. Don't really recommend this because it tends to relax a little bit more when they're lying down. I like to have a little bit of pressure in the gravity to kind of help pull it down, but if you have nothing else to use, then you can do the sheet in the hands and then just have them straighten their legs out, and that'll bring their AC joints down as much as possible. Sternoclavicular joints, be honest, we don't do these that often, so most techs do not know how to do them. Typically we're going to do a PA and then a PA oblique bilaterally. PA view at 40 inches, you can do this upright or prone. Typically you're going to be upright just so you can move them around and use the center line a little bit easier. You're going to center right between the mid-sagittal plane, so right in between the two. So if you put your center line right in the middle of the chest, you should be fine to get this part of the clavicle. You'll be able to see this articulation between here and here, which is where the actual sternoclavicular joint space is. You really only need a 3 by 5 collimation. It's not very big. If you put your fingers on your clavicles, you notice they're not too far apart. Usually only about 1.5 inches to 2 inches is really as much as you need. So you could probably collimate in even closer to that if you really wanted to. Rotation seen between the clavicle heads and spines processes. So just like our regular chest x-rays, what we're looking is we want to see an equal amount of space from here to here, and then from our spines process to each clavicle medial end. PA obliques, we're going to do these bilaterally. There is an important point to notice that's listed here. If you're at 5 to 10 degrees with the patient angle, you are going to be looking at the upside. So if you're doing an RAO position, that means your left side is off the table a little bit. As long as you're in that 5 to 10 degree angle, then you're okay to look at the left side. However, if you go past that, more towards a 15 degree angle, now you're going to be looking more at the downside, because what that's going to do is it's going to kind of open up this portion right through here. It's going to change how much this overlaps over this sternum. You're not going to see it quite as well in there. CR is right between the clavicle heads, so similar to the PA view. Upright RAO, LAO positions on the table, either one is fine. Get both SC joints on there just in case you're just off just a little bit, because you might not angle one 5 to 10 degrees, the other one might be 10 to 15 degrees, so you need to see the comparison between both of them. We're looking at the bottom portions right through here. You should see this a little bit lower on here. This is a little bit high. This is getting the clavicle heads, but we want to see the SC joint, which is right about at the bottom of this clavicle through here. Look at this diagram right through here. This is also what we're looking at through here, and a little bit through here. You can see that this is opening up a little bit more. This one will close up and go across the space a little bit more. So it's important to make sure that you get the proper obliquity of this. Serendipity view for either clavicles or SC joints. This isn't done all that often, but you know, some orthopedic doctors prefer to have this view. Basically, you're just going to do a 40 degrees valid angle to look for fractures, dislocations of the SC joints, or medial third of the clavicles. So they do want to see a good portion of the clavicles on there as well. Sometimes the serendipity view is specifically ordered for the clavicles, but occasionally it will be ordered for the SC joints as well. Usually you just do this supine. It's hard to get that 40-degree angle when they're standing up, so generally you're going to be on the table. We'll do the same thing as an apical view of the chest, but with less angulation, so you can see how high it projects them up into the apex of the chest area. Back should be flat against the surface of the table or the upright bucking. Just a little bit more comfortable position on there. Should be shielded as well. Probably shouldn't have this completely surprised look on her face because she doesn't know what's going on. Collimation wise, that's bad. You should not have collimation showing up on the table. You should be collimated to the edge of your IR. Markers just towards the outside, not only for this particular view but your clavicles as well. There's almost always room towards the outside portion to get your marker on here. And if you are doing AC joints where you're getting the whole thing on there, one side should say with weights or without weights, and the other side should be marked anatomically correct on there. Pretty simple PowerPoint. We are going to cover the AP and AP axial in class of the clavicles. We are going to do the AP AC joints with and without weights as well. SC joints, I'm not sure we're going to have that on the test, but we will clear that up in time for the practicals for you.